Good evening. My name is Doug Thompson, and I'll be presenting the program tonight, Health Beyond the Teeth, the Time is Now. Thanks for joining me, and thanks to Sunstar for offering this opportunity to present to all of you. Just a little bit about me. I've been practicing dentistry since 1997 with a focus on general dentistry in Bloomfield Hills, Michigan. My practice also focuses on personalized periodontal medicine with a total body health focus, including co-management of many patients with healthcare teams to prevent systemic diseases associated with not only periodontal disease but other oral conditions. I'm also a faculty member at the Coy Center in Seattle, board member of the American Academy of Oral Systemic Health, and I'm the founder of the Wellness Dentistry Network. Wellness Dentistry Network is a collaborative global community of dental and medical professionals with a keen awareness about how oral conditions affect whole body health. We also have an online content hub and a team of patient education tools as well as implementation tools to put these concepts into daily practice. I also need to disclose that I do have a financial interest in the Wellness Dentistry program, Wellness Dentistry Network. Let's get started. In 2004, the entire world started to learn about the significance of oral inflammation. In this Time magazine article, we learned that inflammation was really a secret killer, and it's damaging to the body in a number of ways. In the most recent times, there's been works like this book called The Inflammation Syndrome. And what the inflammation syndrome talks to us about is how medicine is redefining vascular disease as an inflammatory disease of the blood vessels. And that's really what that is. What's interesting for us, and where there's a fantastic opportunity for us in private practice, is that it's the bugs that grow around the teeth and the bugs that are involved in periodontal disease that affect our systemic health and that actually have an effect on the system that way. So in practice, years ago, I started to look at this relationship, and it was impossible for me to separate the mouth from the rest of the body. I had people coming to me for really nice aesthetic dentistry and that kind of work, but more importantly, I had people coming to me that once I started to discuss it, they wanted some kind of real life balance, and they wanted real health balance. And again, many of our real already healthy patients want to be healthier, so it's a great opportunity. We have works like this that keep coming at us in dentistry that let us know that 47% of adults at least have some form of this disease. That's what we have here. And that common statements like this, that it's become clearer and clearer that the mouth is the key to a healthy body, and that inflammation is the pathway for chronic disease and organisms to migrate to other sites of the body causing problems. And so it's a great opportunity for us now to enter into a new phase of health-related dentistry. And even lots of companies, and even Sunstar has a section on the website on the Perio link. So it's really becoming mainstream knowledge, and I can guarantee you your patients know about it. Before I get too far into the program, I need to make sure everybody understands the current model of periodontal disease and periodontal disease progression. So what I have on the screen under this green box that's just been underlined is that we need to be aware that the microbial challenge that we're facing today is not just microbes, but it's yeast and viruses as well. This is new to many people, but there's lots of literature supporting this concept. And this microbial challenge stimulates a unique host immunoinflammatory response. And it's this host immunoinflammatory response that, depending upon how it reacts to the bacteria or to the yeast and viruses, determines whether this disease stays confined to the gums, and it's called gingivitis, or whether it moves on into the bony structure that hold the teeth in and creates this dysregulation of bone metabolism, and it becomes what we call periodontitis. And the thing about periodontitis is that's when we see clinical signs of disease. And when we see these clinical signs of disease, that's when a lot of us react. What we have to understand about this disease is that it's biofilm induced. Without the biofilm, it's not going to happen. And it's host modulated. It depends on this unique host immunoinflammatory response. I want to go back for a second and share with you that the host immunoinflammatory response is made up of our innate risk factors, those genetics, and our acquired risk factors. Those are things like, do we smoke? Do we exercise? How do we run our lives? That kind of stuff. So we have to make sure that we take that into combination while we're treating this disease, something very few of us really do. So traditionally in practice, we had our periodontal charting and our radiographic data, and we would look at that and we would see clinical signs of disease. When we would see these clinical signs of disease, what I used to do is I used to wait until the disease outpaced my skill level. Then I would get anxious and I would refer. By that time, it would often be very late in the disease process, and my periodontist would ask me, why did you wait so long? So we really want to try to not be so reactionary. So what I want to talk about that's unique in dentistry today is maybe microbial profiling. And this microbial profiling is getting to be more and more popular. So if we want to look at this green box, this microbial challenge box right here, if we want to look at that box and how it affects the unique host immunoinflammatory response, we can tell you that it's the bacteria, yeast, and viruses that live in the crevice that do that. And we now have good tests, 3 different companies that provide testing information for us about what it is that makes up this microbial load. That's going to be important as we move on in the program. So one of the things also before I get too deep into the program is that when you think about doing a test for somebody that determines the microbes in their mouth, it personalizes the infection. And this was a study that came out in 2015 talking about how if we personalize risk communication, it makes the patient feel very differently about what it is that we're doing. So when we personalize risk communication, patients think their disease is serious. Patients understand that this is a disease of susceptibility, not a disease of neglect. By the way, you don't get this disease because you don't brush your teeth. You get this disease because you're susceptible. You have a high host immune response and you're susceptible. And that's why you get this disease. They also believe that their treatment will be effective and that the treatment advice is going to be easier to adhere to. And they feel positive about the whole overall experience. And so it's really important to personalize the infection. And this slide demonstrates and reminds us what are the personalization factors of this disease. It's going to be the microflora composition right here, and it's going to be the host modifying factors. Without these 2 things combined, you don't have disease. So what we want to focus on a lot is if we could learn about the microflora composition, what does it mean? And how could we treat it? And how could we treat it more effectively? So we're trying to gather data about this disease at a much earlier level so that we can treat it to a more succinct endpoint. That's the idea, and that's what I hope to demonstrate that we're doing in practice. So here's what happened to me in practice. I would have patients that would come in. They had obvious periodontal disease, as you can see by some of the slides. I would treat the patient, and I would do a pre-microbial metric before I treated the patient. And then I would treat the patient to a succinct, what I thought was a succinct endpoint, and I would do another bacterial test, and I was so disappointed because what I saw in the bacterial tests was almost no change. Oh, I saw better periodontal charts. I had better periodontal charts. I had less bleeding, but I didn't have good microbial load control. And today we have a lot of reason to control microbes very differently than we've controlled microbes in the past. And again, that's what I hope comes very clear. So I went to University of Michigan for dental school. I graduated in 1996. And at Michigan, I learned that if I use some kind of debridement methodology, had the patient rinse with chlorhexidine, and I put some patients on some antibiotics, only the really advanced cases, that we had a special appointment, and it was called 6-week hygiene phase completion. And what we would do at the 6-week hygiene phase completion is we would move our patients out to 3 or 4 or 6 month supportive periodontal maintenance, whatever that was. However, I had no chance to look at the bacteria population or the bacteria load. And what I learned at Michigan was perfect for healthy teeth. This is a great way to maintain healthy teeth, but for diseased teeth, we learned we need to do more. I was proud of my Michigan heritage and dental school, and I'm proud to say that I had a daughter that went and played sports at Michigan, and it's been really a nice ride. Here's one of the things I overlooked. Not only did I not know what the microbes were, but I overlooked something else. And if you can see from this pre and post test in our patient John, in the first test, this is the pre-test, you can see higher bacterial concentration than in this post-test. In the post-test, you see the same pathogens, but you see lower concentration. Well, guess what the treatment was for John? The treatment for John was to take out his denture. He doesn't have teeth. So the idea is, I didn't realize the bacteria live so much more on the tongue, the cheeks, the gum, the rest of the mouth. And in fact, I was treating periodontal disease like a tooth disease, and it's really a mouth disease. And so this is what I want to show, and we learned this through microbial profiling. Because this is a fact. Bacteria don't just live in the teeth. They don't just live in the sulcus. They can live for years, decades, as a matter of fact, in other parts of the mouth, like the cheeks, the tongue, the tonsils, and, of course, the teeth. So we have to disinfect the teeth, but we have to disinfect the rest of the mouth. So we created a vision in our practice for our policy. We said we needed to have a periodontal policy that has that definitely involves a comprehensive periodontal assessment. We'd like to have disease detected very early using detailed criteria at the earliest possible stage or even before disease is expressed. That would be really cool, get it really early. We also want to make sure we have care providers that can communicate health awareness, like why is periodontal disease important to your overall health? I'm going to give you a couple really big key points tonight and clearly explain how this risk can affect not only their teeth but their overall health. And we want to make sure we can personalize treatment options. Treatment's not the same for everybody. Why? Everybody has a unique host immunoinflammatory response. That's why. And we want patients and we want treatment that patients can respond to. We want to ultimately achieve excellent periodontal health, and we want to achieve excellent microbial load control. Those are going to be two things. And if you can do that, I can guarantee you you'll eliminate oral inflammation, at least around the teeth. We want maintenance protocols that are effective and adhered to, and we want patients that rave about our service. And I'm proud to say we've created this in practice, and we want to share that same message with you. So there's five key things that I'm going to talk very briefly about in the world of periodontal diagnosis, and it's going to be very important that we understand the meaning and the value of a periodontal chart, periodontal case type language, risk modification. This is part of the list of things that make up the host immunoinflammatory response. And then, of course, our testing, microbes and genetics. What does it mean? I'm going to talk just briefly about a couple of these things. However, before I do that, I want to remind all practices, whether you're an assistant, whether you're a hygienist, whether you're a office administrator, or you're an associate dentist or a dentist, or even you own a practice, periodontal medicine takes a team. And many of these organizations that create top docs and they profile dentists that are the best dentists, many of them want to focus only on the dentist and they neglect the team. And I can tell you at the time of the development of this system and now ongoing, these are some of my current and former team members, and it takes a team of people, dedicated people to make this go. So I want to thank my team, and I hope everyone recognizes that your team is going to be critical as well. So as we collect diagnostic data and we come up with a treatment plan, there's something that we have to do. We have to disrupt or remove biofilm, that's the bacteria, yeast or viruses, to allow a healthy balance that does not initiate an immune response that's ultimately going to lead to tissue inflammation and tissue breakdown. And we have to do it in the office. And in the office, we have mechanical methodologies for cleaning the teeth. We have ways that we can irrigate the sulcus with a potent disinfectant. We need to have potent disinfectants around the sulcus. We also need to think about the fluids that are bathing the teeth, the gingival clavicular fluid and fluids. Could we affect that by putting on board systemic antibiotics, rinse antibiotics, or sulcular antibiotics at the time of disinfection or the treatment? And what about the rest of the mouth? We know that in the office, if we're going to achieve this goal right here of disrupting and removing biofilm, we know that we have to treat the rest of the mouth. So we have to rinse with a potent antiseptic, and we have to find out what's the best antiseptic to use that encourages what? Rebalancing of the biofilm. Rebalancing of the biofilm so that this patient can have a changed biofilm. So in your practice, in your office, all of us can do this. If you want to disinfect the teeth, I don't care how you do it, mechanical debridement, Cavitron, piezo, laser, hand instruments, However you do it, if you can do it effectively, that's a great thing. In the sulcus, we're going to use a lavage antiseptic. We're going to use systemic antibiotics a little more often, and in the rest of the mouth, we're going to use an antiseptic for at least 2 months after treatment. Now, that's part of what we do in the office. That's called scaling and root planing. That's your big scaling and root planing appointment. However, here's the rub. We have to get the patient to do the same thing at home. And how do they do that at home? How are they going to clean the tops of the teeth? How are they going to clean in between the teeth? How are they going to treat the sulcus? How are we going to not neglect what we learned from John? And how are we going to treat the rest of the cheeks, the tonsils, the tongue, and the rest of the oral cavity? Well, they have to have a home methodology for mechanical debridement. They have to have a home methodology for chemical chemotherapeutics, because we know that home debridement and office debridement combined with chemotherapeutics is key to intercepting and breaking down this disease process. If you do one without the other, it'll have little effect on the disease. Oh, back to my earlier point, your perio charts might look better, your patient might look better, but if you measure the microbial load, you'll be disappointed. So we have one really great paper I'm going to refer you to. It's a 2012 paper written by Jorgen Slotz, and there was another paper. I put these two concepts together to look at what are our goals of periodontal therapy, just to see that it's confirmed in the literature. We want to achieve a periodontal environment that's free of pathogenic microorganisms. We want to include mechanical debridement. It's key, but so is pharmacotherapy. If you have mechanical debridement without pharmacotherapy, and you just do routine scaling and root planing without the use of any kind of chemotherapeutic agents, you're going to have little effect on the disease. And what's our goal? What's our goal if we're thinking about this biofilm? We want to eradicate, suppress, or alter the combinations of these pathogens as they relate to gingival health. I want to say it one more time. We want to eradicate, suppress, or alter the combinations of pathogens as it relates to gingival health. It takes a lot more than I originally thought to do that, and that's the goal of tonight. In this low-cost periodontal therapy, Dr. Slotz goes on to talk about some disinfectants, but I can tell you, and I'll cut to the chase, he evaluates chlorhexidine, iodine, and chlorine-based agents, as well as fluoride and bromine. And in that paper, he talks about how sodium hypochlorite, chlorine, is a highly active agent and one of the most potent antiseptics we have against bacteria, fungus, and viruses. And I want something that works against bacteria, fungus, and viruses. That's going to be critical. We know that sodium hypochlorite kind of occurs in our body naturally in human neutrophils. It doesn't evoke allergic reactions. It's not a mutagen or carcinogen. Remember, we're talking about in this paper, he talks about a very dilute solution of sodium hypochlorite, a 0.2% solution. You might know grandma's bleach or bleach at home as, 5%. This is a very, very dilute solution of sodium hypochlorite. And it has a high pH, which is great for pH adjusting, has a century-long safety record. And when we compare sodium hypochlorite to iodine and chlorhexidine, dilute 0.2% sodium hypochlorite has no contraindications, and it's the most powerful antiseptic of choice. This was amazing to me. I never thought that this would be something I would consider, but I use this routinely in practice now. And when we look at sodium hypochlorite, it has a broad antimicrobial activity, an 80-fold decrease in biofilm endotoxin compared with water alone. So it's a very, very good disinfectant. And in fact, the American Dental Association has said you can use dilute sodium hypochlorite because it has a basic pH, no risk of tooth erosion, no detrimental effect on periodontal healing. By the way, chlorhexidine can have some negative effect on periodontal healing. And dilute sodium hypochlorite has no contraindications. And what I'm leading up to, is a product we do have. I'm not going to talk about specific products on this webinar, but I can provide that information if you wish. But we do have a 0.2% dilute FDA-approved sodium hypochlorite rinse that we can use daily in our practice that's safe, where we're not asking the patient to go home and mix something at home on their own. So it's very good. And this, in fact, is the disinfection protocol that we came up with that changed the way our patients respond. Now, many of you are saying, I can't read that. No question you can't read that. I've provided this in your supplemental handout materials. So you have this and a couple articles that I either authored or co-authored so that you could go through step by step what we're doing as a baseline disinfection protocol before we start doing other things pertaining to host modulation. So as I look at periodontal charting, which is the backbone of our periodontal exam, our comprehensive exam, and we use bleeding as an indicator of disease activity, and we classify the disease so we can determine how aggressive or non-aggressive the disease is. And then we look at risk modifiers, the things that affect the unique host immunoinflammatory response. What would some of these things be? Smoking, diabetes, heart disease, sleep apnea. Do you have implants? Do you plan to place implants? Do you have other rheumatic illnesses? These are all modifiers that affect the disease process and affect our ultimate treatment. What I want to do is make two brief comments, a little bit more now about microbes, and then something about genetics, which we can also test for as part of the diagnostic data gathering. I'm going to talk more about microbes, yeast, and viruses, but we have virus tests now. We have companies that have viral tests, and we have companies that make yeast tests. And these yeast tests actually speciate yeast, and they will give us a breakdown of the type of yeast that's present, which is very nice. And we have genetic panels as well. I want to give you a brief look at a genetic panel. When I first started in this venture, I could only measure interleukin-1. That was the only thing I could measure. Now we have beautiful genetic panels of 8 different biomarkers. And these panels are broken down into innate and acquired risk factors, which helps us understand the disease more. But interestingly, look what else the companies are doing. The companies are giving patients, this is a dental company now, and what is it doing? It's on the report, it's telling patients how this genetic predisposition not only affects periodontitis, but how it can affect cardiovascular disease, type 2 diabetes, and other rheumatologic conditions. So patients are starting to hear more and more and more how not only their genes, but how their lifestyle affects this disease and the disease progression. So here's what we would love to have happen in practice, and here's what we have happen now quite routinely. We have a patient, 62-year-old patient, clearly has evidence of periodontal disease. When I go ahead and do a bacteria chart, we see a lot of pathogens. These charts give us the concentration of pathogens, and they give us the concentration of pathogens and the presence of pathogens by a nice colorful profile. These black bars, by the way, are called threshold values. And what these black bars mean is that if the bacteria is present over the black bar, it just means the relative risk of bone breakdown for that patient is higher. It doesn't mean they're going to break down. It just means the relative risk of bone breakdown is higher. So I routinely, at disease identification, collect a very comprehensive periodontal charting and collect microbial testing data. Why? I want to compare this to post-treatment data as well. So when we take Chris and we treat him to disease stability, which is represented by 0 bleeding and a changed, and now what we're looking for is changed biofilm, only once I see 0 bleeding will we go ahead and do another bacteria charting, and this is in fact what we'll see. We'll see 0 bleeding on the periodontal chart, and we'll see a microbial profile that looks very different than the microbial profile that we took at disease identification. And we want to see that, and we want to see that patient after patient, time after time. Now, one of the questions that could be asked is, how long will it stay that way? Can you keep it that way? So I want to use a little bit more case data to show you where we've come in practice. So I'm going to take that same case that I treated earlier on with my conventional scaling and root planing like I learned at Michigan, and my pre-treatment data and my post-treatment data, which look very similar. We went ahead and retreated that patient. But we retreated that patient after we paid attention to the sulcus, the rest of the mouth, a much shorter recare frequency, and a much more robust home antiseptic usage policy, water picking. Again, it's all on the disinfection protocol. And here's what happened. We treated him this way, and we really don't need to read what's on the screen because I'm going to go ahead and summarize for you. However, we did do full mouth SRP. We did irrigation with a sodium hypochlorite product around the teeth. We did use a time-release antibiotic around the teeth as well. And we dispensed a sodium hypochlorite rinse, and we asked them to use it daily for 1 minute, twice a day. And we did that for 2 full months. We put them on the antibiotic regimen that was suggested by the bacteria charting, and we requested that we see him back in 7 weeks for reevaluation. So he came back and the pocket depths were decreasing nicely, except there was not an absence of bleeding. So now we're out 2 months, and we said we're not going to retest at this point, we're going to wait. So we continue the rinse system, and I'm going to encourage you to continue the patient on some strict, tight recares and strict twice a day, 1 minute with a very potent antiseptic until there's 0 bleeding, or until they figure out how to do at home what you help them do in the office. That's the idea. And so 7 weeks later, in July, came in, he looked fantastic. He felt great. This is when patients will often tell you, I know it's going to be better today. My mouth feels fantastic. It's a really nice, rewarding appointment. Here was his pre-test data. Here was the data after I did conventional scaling and root planing. And this is the microbial chart after a much more intense, robust disinfection protocol. So here's what happened to me. I just learned from this experience that I wasn't doing enough to manage the microbial load. And if you think about it, as dentists, we are in the microbial load business. And of course, we're in the restorative business and all that other stuff, but we are in the microbial load business. And if you think about caries management, periodontal disease management, those are 2 biofilm-mediated diseases, and we need to have fantastic microbial load methodologies. And if we don't have it, and if we can't prove it by a test or show it, then all bets are off. I don't know who has it and who doesn't have it. I know because I was getting better periodontal charts for years, but I wasn't getting microbial load shifting. So how about 2 years, 2 months post-treatment? 2 years, 2 months post-treatment. Here's the pre and post-test data now. And now here's 2 years, 2 months. 2 years, 2 months, he's still doing very fine. And this post-treatment data right here looks nothing like the pre-treatment data. And he's still doing very well. 3 years, 4 months, what happens, you'll see patients will start to stretch the time between appointments. You have to watch them very carefully. And at 3 years, 4 months post-treatment, here's still a microbial chart that's very different from the initial disease presentation. Now, I used to have people tell me, oh, the periodontal disease will come back in a year. It's going to be right back. I can tell you through this methodology, periodontal disease can remain stable for years, especially if you keep patients on relatively tight recare. 4 years, 3 months, when you start to see spotty bleeding like this is time when you can have them bolster up something at home. You could have them go back on the more potent disinfectant rinse, but they'll never get back to where they were. So here's his post-microbial data, and here's the microbial data at 4 years, 3 months. How about 6.5 years out? 6.5 years out, we still get charts that come in, chart after chart with very little bleeding or no bleeding, bacteria profiles that look very unlike the initial bacteria profile. And now this is 8 years post-disinfection, and now I have 9-year post-treatment data on this particular patient. This was just January of this year. 9-year post-treatment data. The periodontal charts continue to look great, and the patient's microbial load never, ever went back to look like it did in the pre-treatment levels. And what I would hope we would do is we would do this on patient after patient after patient. That's the idea. And so here's our biofilm management chart over 9 years. We eliminated all high-risk pathogens. I didn't mention earlier that these tests break the patient's biofilm down into high-risk, moderate-risk, and low-risk pathogens. And it's good to know these high, moderate, and low-risk pathogens, as you'll see in the remaining 15, 20 minutes of the program. You'll see why that's so significant. But the idea is we need to come up with some methodology to show that we can control biofilm on patient after patient for years and years, so they'll never regress to where they were when you started to treat them. This was one treatment, one round of antibiotics, just great home care, great patient education, and great disinfection protocols in the office. And we've taken painstaking data to look at all the different permutations of what we've been doing in practice so we could come up with these kinds of conclusions. So here's the unexpected realizations from this process. I learned that measuring microbes personalizes the infection and helps us communicate and relate the disease to our patients in a way like no other. I know that when we talk about the host immunoinflammatory response and the uniqueness of everyone's disease personalized to themselves, it just erases that burden of neglect. They start to realize it. I have had a good opportunity to discuss immunoinflammatory response and systemic inflammation and how it relates to health. We have much more treatment acceptance, much better treatment results. One of the keys is keeping the evaluation very short, 8 weeks until zero bleeding. You could even be shorter. No retest till zero bleeding. Biofilm is not easy to manipulate if you measure it, especially. And we get incredibly improved treatment outcomes. But here's the biggest thing that I learned, and it's going to come up as item number 10 here. The average time with our care until a patient gets to stability is 4.5 months. So this idea about 6 weeks, 7 weeks, 8 weeks, if you start measuring microbial profile, you'll see it's just not going to be enough. And I think many of us are giving up on this game way too early. And this is a disease that once it comes full circle, we're going to realize we still treat it like mechanical, like it's just something we can scrape away. This is a very complex polymicrobial disease, very hard to control with a scalar. So going back to the paper about systemic health, the question is now this: could long-term biofilm management have other positive health effects? And that's where I want to go with the rest of the program. And what I want to talk about as we learn that inflammation is now the silent killer, how is inflammation implicated in other diseases? It's very implicated in heart disease, and it's the bugs around the teeth that make a difference. Do we have some science to show that? Do we have some literature to show that? We really do. The people that really understand vascular and arterial inflammation are two of my friends, Dr. Brad Bale and Amy Doneen, and this is a book everyone should have in their office up on a shelf for people to see. And what they've helped us understand is that these bacteria pathogens affect vascular biology. And I can't get into it in depth, but what I can do is give you a brief look at how this affects vascular biology. And what they feel so strongly about is physicians cannot manage vascular disease comprehensively without a thorough oral inflammatory illness evaluation. The only one who can do that is a dentist. So I think it's a great opportunity for us in practice. I want to share with you a little bit about what a vessel looks like. Under the first red circle is a normal vessel. It has a small lining that lines the blood vessel that keeps the good stuff out and the bad stuff in. And if you start to get atheroma or fatty buildup in the vessel wall, you'll get this atheromatous buildup, and it starts to expand outward, not typically inward. It expands outward. And if you have too much inflammation and a lot of inflammation, it can create instability in the plaque cap, and you can have some blood spill out into the bloodstream, a clot forms, and that's a sudden heart attack or a stroke. So the nice thing about this is there's biomarkers that can be measured along the way, and our physician colleagues can help us measure these biomarkers, and it can tell us if the patient's having problems in any of these areas. Because we have evidence to show periodontal disease is involved in how elastic the vessels are, how functional the skin-like lining is that provides a semi-permeable membrane, a lot like the epithelium around in the gingival sulcus. Also the HDL to do its job, the atheroma process, the building up of atheroma, and these biomarkers are key pieces. These are key measurables. If you want to manage heart attack and stroke, these are key measurables that need to be measured on a regular basis. Some of these are indicators of disease risk, and some of these are indicators of disease activity. When I was at Michigan in 2005, Walter Loesch, I wasn't there then, but Walter Loesch was studying the effects of LP-PLA2, which is indicative of atheroma activity and periodontal disease, and there is a correlation. So we have an inflammatory panel that we use to measure, that we can use to even take this to the next step as we move more into medicine. We can have an inflammatory panel that we can relate to these inflammatory biomarkers that we have science to show periodontal disease can affect these. So as a matter of fact, they feel so strongly about this that they use these inflammatory biomarkers because inflammation is the driver of a heart attack or stroke. They can use these inflammatory biomarkers to help determine who might be at high risk for a heart attack or stroke, and they feel so confident that people under their care won't have a heart attack or a stroke. I think that's amazing. So there's also 8-year outcomes that look at their program and talk about the benefit to cardiovascular health. And this method that they outline in that book is effective in generating a positive effect on the atherosclerotic disease process by achieving regression of disease in the carotids. And there's their study to do that. They also published an additional study that I'll talk about in just a second. But what they teach us in their preceptorship courses, and I recommend all dentists and hygienists take their preceptorship course, is that some of these risk factors are also significant risk factors. These are risk factors for cardiovascular disease. Many of these are risk factors or risk modifiers for periodontal disease. And look at some of these: smoking, rheumatic arthritis, stress and depression, psoriasis, obstructive sleep apnea, insulin resistance, diabetes. 80% of all diabetics will die from a heart attack or a stroke. Think about how many people are sitting in your chair that have some of these issues and have periodontal disease. Well, I'm going to show you one of those patients and what happened when we looked at one of those patients. Because this is what I want to prevent in my patient population. I want to prevent anyone from taking this ride in an ambulance. And how many people are going on that ride each month? About 60,000 people die every month from a heart attack or a stroke. Every 40 seconds, somebody's having a heart attack or a stroke. Over 60 people while we've been, well, way more than 60 people while we've been going through this presentation. So looking at, before I go on to further, looking at a nice paper, just one paper that I want to give you that links periodontal pathogens to cardiovascular disease. It looked at 152 different references. It was a review paper. It looked at how periodontal disease can be affected by, or how cardiovascular disease is affected by our innate and adaptive immune systems. Sounds familiar? And bacteria. And there were 97 well-documented papers of the influence of periodontal disease on vascular disease. And what was it on? It was on lipid biomarkers, blood characteristics, other different biomarkers like the biomarkers I mentioned earlier, and antibodies. So the idea is, could we be coming on a time where we're using these in practice to help our periodontal disease patients understand more about their risk for cardiovascular disease? And the answer is yes. So Dr. Bale and Dr. Doneen and Dr. Vigorist also produced a paper that looked at high-risk periodontal pathogens and their effect on endothelium, lipids, and on smooth muscle binding. And what they concluded is periodontal disease due to high-risk pathogens is causal of changes in this way and has an effect on the vascular disease process. I think that's a huge opportunity. And when we look at books on this disease, books on periodontal disease and the relationship, we're looking at specific pathogens are named. So they're not just saying periodontal disease, they're looking at Porphyromonas gingivalis, Fusobacterium nucleatum. So it's time really that we learned what's in the microbial composition. And this book is a beautiful book called The End of Alzheimer's. And this book is a must-read for everybody that has a parent or a loved one with Alzheimer's about the significance of oral bacteria. And again, this also paper from Inger Olson about oral infection for risk factors for Alzheimer's is a great, great paper to look at. So this patient Joan comes in. She has some risk factors for heart disease, and she has obviously aggressive periodontal disease. But she has diabetes, hypertension, reflux disease, active periodontal disease, and we did a bacteria chart. The bacteria chart wasn't so moving. She was referred to me because I measure for yeast, and someone thought she had a yeast infection. But I asked Joan, I said, Joan, I'd like you to get your vascular health exam. And so she went, and at this point it was a Boston Heart Lab report. And she went and got a Boston Heart Lab report, and I know you know the significance of red, yellow, and green, but I'll explain it more to you on the next page. This report breaks heart disease up into lipids, inflammation, metabolics, and genetics. If you took this and replaced it with bacteria, it's pretty much periodontal disease. So what this says is basically they personalize the report and they say, Joan, you're in danger because you have a high risk of forming a blockage. She had a severe, severe dyslipidemia. Additionally, when we looked at her inflammatory biomarkers, which Dr. Bale and Dr. Doneen teach us is maybe even more significant than lipids. It says, Joan, you're in danger. You have too much inflammation that can cause damage in your artery wall lining. This is how blockages can form. She had a significant elevation of dangerous inflammatory biomarkers. And this paragraph right here says this. If your inflammation is not addressed, you have an increased near-term risk within 1 to 6 months of a heart attack or a stroke. If you're the dentist that helps your patient figure that out, I can tell you they look at you very differently. And all I did was refer her down to somebody who knew what to do. So that's how we use this. Now, how am I using this more in my casework? This is a case of a patient that came in. We collected a medical and dental history. He hadn't been to a dentist in years. You clearly can see there's disease. This disease is typically caries. However, as we look further into his clinical slides, you can see he has a lot of disease, but he hasn't been to a physician. And he has also periapical disease. So he has both periapical and periodontal disease. What I would love to know, since he hasn't been to a physician, is I wonder what his vascular health looks like. He clearly has periodontal disease. So what we get the chance to do now as dentists in our Wellness Dentistry Network, we can actually order an inflammatory panel from a bona fide heart laboratory. We can do this ourselves that help us determine if he's at high risk in any one of these areas. We have a disclaimer and we recommend that a physician review this, but it helps us determine if we do really have a problem before we start to do our work. And what we're going to do is start collecting these metrics pre-treatment and then look out 1 month, 3 months, and post and after, and look at what was worse, what gets better, because what we need is hundreds of these cases where we show that dentistry truly does significantly affect vascular biomarkers. That's what we're going to try to do, and that's what we're set up as a network to do. We just are in the early stages of developing this idea. And we can do things like this in practice. You see a Panorex. When you see this little potential calcification on a Panorex, it's a really good idea to send this patient for some further evaluation. So I sent this patient down for a carotid scan to look at his carotids. What was the results of his study? This was a 28-year-old male with a potential differential diagnosis of a carotid calcification that was determined. He had the arteries of a 51-year-old and he already had a heavy plaque burden. So he was more diseased than 90% of men his age. This is a 28-year-old. This is what I think we should be doing in practice every day. We should be finding these cases out and taking care of them. I'm going to cut to the chase on this. There are medical cost savings from periodontal disease treatment, but this is a study that was done with almost 335,000 people, and some of these people had different diseases: diabetes, rheumatic arthritis, cerebral vascular disease, coronary artery disease, and some were pregnant. And there was a combined claims database. So what that meant is the dental codes and the medical codes were shared. So the company could see who had dental treatment and who had medical treatment. And what the data table shows is we have lots of patients that had diabetes, cerebral vascular disease, coronary artery disease, or rheumatoid arthritis. But when you looked at the untreated and treated group, I'm going to summarize it on the next slide because it really states what's happening in our profession. We had 205,000 sick patients in this study. Only 1% of the patients had dental codes that showed they were treated for periodontal disease. So, and these patients had periodontal disease. So it was really, really evident that we're undertreating the disease, and that's because we don't have clear entry criteria for when to identify and treat this disease, and we don't have clear objectives of treatment. And that's what I hope I can help bring to our profession. Is there cost savings? Huge cost savings. Huge cost savings for sure. So that goes without saying. How do I monetize this concept in practice? People say, how are you going to make money looking at this? What are you going to do? I just want to show you one patient. This patient was referred to me for elevated myeloperoxidase. This is an enzyme that's elevated during a heart disease and cardiovascular risk issues. And I don't want to get too deep into this patient, but what I want to share with you is this patient wrote on her health history, I have elevated myeloperoxidase. So what happened to her is she needed periodontal therapy. She wasn't treating her sleep apnea, so we put her into a Herbst appliance. We helped her with acid reflux. We increased her exercise. We did this with her physician. And what happens is her myeloperoxidase over a year and a half continued to show steady, nice decline. This is a great collaborative effort by me and her physician, and Pat, in fact, spent about $9,000 in the practice. And so this happened over a year and a half, not so much. Now, how about some other patients? Steve was referred to me by a chiropractor that wanted somebody who understood how to manage a heart issue. He spent $68,000 in the practice. Bill came in for elevated HSCRP. He spent $37,000 in the practice. What I'm telling you is these people that get referred in by physicians for elevated biomarkers, because you know how to do an oral inflammatory illness evaluation, they have other disease and they have dental disease, and you'll be able to treat them. In fact, in our network, we not only treat these 7 key dental elements, but we like to have methodologies to discuss all these things with our patients in a very easy format. And that's what we're continuing to grow in our networking. So this is so true. This is so true. When you're healthy, you want a million things, but when you're sick, you only want one. I thank my friend Boley in Boston for reminding me about this truism. And there's one thing that's really critical about this whole wellness movement and why this is successful. It's successful because it's unique, it's relevant, and it just so happens to be true. So I hope that many of you would start to join your journey on your journey with wellness, and you would continue to grow in this modality. Because what I've learned is microbial profiling is invaluable to me. It's very valuable for the number of things that I've already talked about. I know that periodontal disease contributes to overall inflammation. I don't need to be convinced of that. I also know that treating periodontal disease has medical cost savings, so even if you're not measuring anything, you know you're helping your patient financially. And there's a great opportunity because there's physicians that really want to work with us. They want to work with us, and they need us. They told us they need us. So it's great. And it feels great to practice this way because I know I'm really, truly making a health difference. It's amazing. And what's the result? Healthier patients, a healthier practice, and for sure, healthier teams. So as I close this portion, I'd like to field some questions. And again, before I get into the questions, because I might not get to all of them, there's actually quite a few. I really want to thank Sunstar, and thanks to everyone who joined me on this. We're well over hundreds of people are joining us tonight, which is great. And if you'd like to connect with me or learn more about these concepts, you can email me personally at just Doug, D-O-U-G, at wellnessdentistrynetwork.com. But what I'd like to do is I do have a question from actually a Canadian, one of my Canadian colleagues and friends, who says, how do we make use of the U.S. lab testing from Canada? We do have some nice opportunities in Canada, and Canada can get this testing done, and much of this testing in Canada can be done through your social medicine system. So we have network opportunities in the library. There's physicians that understand this language and that can help you down that road, but it is available. And also the bacteria testing is available in Canada as well. So I have another question about oral probiotics. Do I believe oral probiotics can play a role in oral health? I do believe oral probiotics can have a role in oral health, but it's not yet clear. We don't really know about the oral probiotics, basically the role and what they're ultimately going to do. I did some testing with oral probiotics, and I did get shifts in biofilm, but I didn't get reductions in bleeding. So I'd love to do a study with some of my patients, but I can tell you measuring these microbial profiles can be expensive, and I did all this research in my practice on my own, at my own expense. So I really think that some companies need to really do some great tests, and they need to do some tests on real live clinical patients and see what happens, because I think the jury's still out on that. I do have another question about, is testing covered under medical insurance or dental insurance? I don't bill for either. I do tell patients, I look them directly in the eye and I tell them that there's a test that's available that will help me treat them. It's going to cost about $100. Most of these tests are around that much money. And I would tell them that, I would say to them that it's something that I need, not to determine if you have disease, but to determine how to treat you. That's what I have to. That's what I need this for, and it's so valuable. You could give it to them for free, and you could present a treatment presentation package, basically a disinfection package, which we recommend doing, and you could build it in. There's a great opportunity to use the metrics, and I guarantee you that there's codes for it for sure. I don't have experience billing for them. I want to ask another. There's another question: is sodium hypochlorite more effective than chlorhexidine as an antibacterial used with SRP? Absolutely. I did not determine that. Dr. Slotz determined that through his studies. There's plenty of literature out there on bleach or dilute sodium hypochlorite and the effects on the disease process. I have another question about the, this is a question I want to make sure there's no confusion, because it asks, is the test based on blood or is it a biofilm sample? Now, the oral test is based on saliva. Some of the companies ask you to take some paper point samples and maybe do a swab, but it's based on biofilm taken out of the mouth. Now, our Cleveland Heart Lab panel and our blood biomarkers, that's definitely a blood draw, and we have a blood lab do that for us, and there's blood labs in your area that can do that for you. We do not draw blood in the practice. I don't handle blood in the practice, and I make sure that I have consult on the results. But that's a nice question. I want to go down, and I'm going to have a lot of fun, but I really, really wish people would stop writing "Go Buckeyes." I mean, I get it. It's terrible. I get it, but so I'll give you that. Anyways, there's another great question. I mentioned a study that was done in 2015, and to this date, how much more importance has been given to all these. You know, we use a lot of data to determine significance of our clinical modalities. This journey for me began in 2009, and now we're in 2018. So what I have to show is some of the studies that validate what we did along the way. I can tell you there's no studies that have done anything but further validate what we've been doing in practice. So I think it's a great opportunity, and it just gets further and further cemented. What I think we have more science on now is this effect on cardiovascular disease and periodontal pathogens, now up to 57 cross-reference diseases, and some published article mentioned as many as maybe 200. I can tell you that we are the gatekeepers of a potential infectious source that is much, much more powerful than we've led this to believe, than we've been led to believe. I have I also have a question that's a really good question. What is effective against yeast? That's important because yeast is a big player, and yeast is going to get to be more and more understood as we go further into the future. And so the dilute sodium hypochlorite is very effective about yeast, and we're continually evaluating other antimicrobials. And if you're going to evaluate an antimicrobial, just do the pre-test measurements and post-test measurements to see what kind of difference the antimicrobial makes for you. If you can do that, that's a very nice way to find out what you want to, what you're looking at. That's really key. I have another question, and I'm not supposed to really mention products, but we have some maintenance rinses that we use, and those are typically chlorine dioxide, and you can get one of those at the drugstore. But the chlorine dioxide product is, we do have a favorite, and I think it's mentioned in our disinfection protocol, and I think that that's the chlorine dioxide maintenance rinse that we would like to use. It's a chlorine-based rinse, but it's a lot lighter than the one that we would use for disinfection. Frank asked me about the handouts. The handouts are online, and they're available for you on the website, on the Sunstar website. Another question we have is how did you charge the patient for the bacterial charting? Bacterial charting, the periodontal examination, is part of our comprehensive oral evaluation. And again, as part of our comprehensive periodontal assessment, or the vision that we put place in our periodontal policy, if you will, we wanted to make sure everybody has a comprehensive periodontal evaluation. Periodontal charting is part of it. And I know there's a lot of reasons why people don't do periodontal charts. Time, knowledge, no support, no help. But without the periodontal chart, you're really just dead in the water. I actually have people that I go to their offices and look in some of their exam kits, and there's no probes. So we really have to probe, and we have to do periodontal charting. And on the periodontal chart, I didn't mention it earlier. This is a good question. On the periodontal chart, I want to make sure that you understand we need to have recession, we need to have probing depth, and we need to have bleeding. And in our network, we work with a tool called the Papilla Bleeding Index, which is a great tool to evaluate bleeding. And we need to have that information, because every single time a patient comes into your office and sits in the hygiene chair, the first thing they need to do is, within the first 5 to 7 minutes, is an accurate periodontal chart that reflects how they showed up that day. That's for sure. And that periodontal chart is going to be the determining factor whether you're going to talk about, oh, hurrah, I'm glad you do what you do in between your teeth, or I think we could do more for you. And now I'm going to stop and talk about this too for a second. I used to think that patients were neglectful. I don't think my patients that I was trying to get healthier all have a learning disability. I think we had a teaching inability. We weren't giving the patients the tools that they needed to be successful, or the methodologies. And now when we do that, it's changed the results. So think about your patients when they walk into the hygiene room. If they have bleeding gums, please, you should mention to them, give them tools and methodologies. And so what I say in practice is, we can do more for you. We can help you learn more about what to do. It's not what you're doing at home. It's we can help you. And you take patients from no flossing to flossing, no interproximal management to interproximal management, no rinse to a rinse. You just keep graduating them up to something stronger and stronger until they can be successful at home. I have another question about the protocol for the rinse that we use for disinfection at home post SRP. That rinse is going to be used for 2 full months, 1 minute, twice a day. I know the taste might not be great of some of the rinses that are out there, and you tell them it's a medicine, not a refreshment, and they need to rinse with it because it's going to alter the biofilm over time. And the biofilm needs to be continually attacked over time, and that's the key. So we need to remind our patients that. And they don't, for maintenance for a lifetime, they can either use a lighter chlorine dioxide-based rinse, or they can use intermittent, they can rinse intermittently with that product. There's other things they can do over time. The other question is, I'll try to take another question. I have many of them, but I want to I wanted to see if there's another one that I could answer. Charles asked me about ozone. Ozone's a disinfection modality. I'd love to use it. I just love to see some great metrics. I also would like it to be easier obtainable, and I would like it to be more widely recognized as a potent disinfectant. But I think there's great hope for ozone, and I just have to do more for it. And and it's not what I used. It's not what I used in my protocol, so I have to make sure that I disclose what I used. Brenda's asking me about a particular product, and I think it's Biocidin. Biocidin is a biobotanical drop. That's something that we're just starting to experiment with, and I don't know how to measure the effectiveness of that yet, but we are using it for some of our very holistic patients that want an all-natural biomechanical or a good endpoint. Another question as we start to close. Can you mix the 2% sodium at home? You can. In the Jorgen Slotz paper, he talks about it and how to do that very well. Closest and some of the drugstore products are not a replacement for sodium hypochlorite. There's nothing better than that. So I'm very happy to field questions. I want to be very courteous of the time I've been given to do this presentation. I know it's a ton of material, but I want to make sure that I wanted to get as much in as I could. I know it's recorded, and so I think that there's opportunity for you. I know there's some people reported a small audio problem in the beginning. We'll have a clear recording for you and make it available. Thank you so much, and again, I want to give special thanks to Sunstar and everyone who took the time out to join me tonight in person, and for those who might listen to the recording in the future. Thank you.